Hi, everyone, and thank you for joining us. My name is Amy DeLong, and I'm the manager of federal government relations here at Boston Children's. Here to welcome you to the panel today. Folks on the panel, feel free to turn your cameras off, keep yourselves on mute until it's your turn to talk. I just want to welcome everyone and thank you for joining us. We're excited at Boston Children's to be able to virtually host this event. I think we had more than 100 viewers registered from across the country. People are logging on right now as we speak. And I know it's all people who are interested in learning more about the Medicaid provider and screening and enrollment initiative that we've been working on for several years now. And you'll see from the speakers today on this issue, which is really at its core an administrative issue in nature, but it impacts real patients. And it's often our most vulnerable patients that are impacted. So it's one that we are committed to fixing. And at Boston Children's, we have a deep and longstanding commitment to serving children on Medicaid. In our own state, we're part of a pediatric Medicaid ACO with over 100,000 covered lives, and this commitment extends to our out-of-state Medicaid patients as well. We are the regional pediatric safety net for the New England region, and we work closely with state Medicaid agencies and their managed care plans to support children and families with complex care needs. So I'll be moderating this event, and I'll be turning it over soon to this fantastic panel that we've arranged in a few moments. But I wanted to say a few things up front. We will be taking questions for the panel, and we'll ask all the questions at the end after all the speakers have had a chance to speak. So you may submit questions at any time using the Q&A feature on Zoom. Just type your question in the Q&A feature, and we will try to get to as many of them as we can. The chat, which is separate from the Q&A feature, will be open throughout the event for conversation and comments, and we'll use it to drop links to resources. So feel free to look in there. We encourage use of the chat, but especially knowing that we do have folks on this call from other hospitals who might be helping patients through a range of issues. We just wanted to remind people not to share any HIPAA protected information in the chat or verbally on this panel. If you have specific case issues or problems that you need help working through, the most appropriate thing to do is to reach out after the event. I'm happy to help facilitate any connections. And Nick, who's helping us monitor the chat, will put my email address in the chat so that you can find it there. It's amy.delong@childrens.harvard.edu, and it will be in the chat. I also want to tell people that this event is being recorded and it will be available to watch after. So if you miss part or want to watch it again, that will be possible. Our panel includes two physicians, one from Boston Children's and one from Seattle Children's, as well as a patient parent who's traveled from out of state with her child for care here in Boston. We'll also hear from Josh Greenberg, who's the Vice President of Government Relations here at Boston Children's, and there'll be brief videotaped remarks by some of our legislative champions. We hope that you'll come away with an understanding of the issue that out-of-state providers of care to children face, or one of the issues they face, and that you might be motivated to take action to help our bill move along in the Congress. The first speaker is Dr. Peter Lawson, who's the Executive Vice President for Health Affairs at Boston Children's. Dr. Lawson is a member of our senior leadership team and oversees the medical delivery system. He also sees patients in our cardiac ICU. So his background with complex patients certainly informs his perspective as he considers how we can best serve all children who need our care. And I'm going to turn it over to him now. Thank you.
Thank you, Amy, very much. Hi, everybody. Good afternoon. It is a pleasure to be able to speak to this very important legislation. And first, I want to really thank the people driving this important legislation, not only from our government relations team here at Boston Children's, but many of our peer institutions across the United States. This is not an isolated problem. This is a national problem. And I want to thank the sponsors and co-sponsors for this legislation as well. I think the success of passing this legislation will really improve the care we can provide to vulnerable and highly complex care for children. As Amy mentioned, my role as EVP of Health Affairs, I overlook the quality of care that we deliver at Boston Children's. And also, my clinical experience is 30 years in pediatric cardiac intensive care, a very highly complex and intense environment. And within that environment, on many occasions, have had to manage circumstances where patients needed care but were denied access. because providers were not enrolled in a specific Medicaid plan in another state. And really the bottom line here is that Boston Children's and our peer institutions, Seattle Children's and many others across the United States, are committed to serve Medicaid patients and to provide the care that they need, particularly for the most complex. It's about doing the right thing for these kids and taking away the red tape. It's a barrier to access that adults don't experience in Medicare. Why should we see that in pediatric patients? You know, in a crisis during this pandemic, waivers were created and different rules were implemented so that care could be facilitated across borders. We should not go back to the old ways. We can do it. We've seen the way it should be done, I think. So with that preamble, who are the patients we're talking about? Well, the categories of kids that really need to come out and travel out of state for care fall into three groups. They may have very rare or unique conditions. They may have where the care for that unique and rare condition is centralized into specific centers. There are other children that have really straightforward conditions, but have underlying medical complexity because of other associated illness or comorbidities. And care is not evenly distributed across the United States, as I'll show you very shortly. And that means expertise is not evenly distributed across the United States. We have to recognize that. That's the nature of the healthcare system here and population densities. So Boston Children's Hospital and our peers are committed to serving children who need our care, regardless of race, regardless of any barriers around race or ethnicity or socioeconomic background. And many of the vulnerable, complex patients within Medicaid fall into this problem where either because of race or socioeconomic background, they're unable to get the care they need. So we want to be able to eliminate the barriers for children. Thank you. Next slide, please. One of the things that's accelerating this need is that pediatric care is increasingly becoming regionalized. In other words, concentrated in areas of expertise related to subspecialties. And it's not only about a single or unique provision of care, but it's also about the teams of people that are needed to take care of these patients. So we have specialized care teams from nursing through various therapists, all who are involved in coordinated care. It's not one individual, it's a team of individuals that provide this complex care. Regionalization also enables us to concentrate resources and technology with that expertise. And so the aim of this legislation is to streamline the screening and the enrollment of providers treating pediatric patients in out-of-state Medicaid plans. And it's really a focus on timely access to care by providers. And I want to really distinguish, we're not talking about authorization, negotiated payment for care. It's about access, timely access to providers who can provide the complex care that is required. Next slide, please. So pediatrics is quite unique. I mentioned the regionalization that is occurring and changing the landscape across pediatric care. I mentioned that there are different circumstances between adults in Medicare and children with Medicaid. It's important to understand that pediatric care is not the same as adult care. Illness in children consists of different disease profiles, many of them originating at birth through various genetic defects, often associated with other system problems and comorbidities. And management is not isolated. It is a longitudinal care because the manifestation of illness and evolution of disease is affected by age and maturation. One thing we do know that is very, very important is that the earlier you intervene in the treatment of a particular disease or condition, then that will set you up for not only the need for longitudinal care, but in particular for quality of care of life. Some 20 years ago, the Secretary for Health in the Clinton administration coined the term that children were 20% of the population and 100% of our future. Right now, they're 23% of our population, and they're still 100% of our future. So early intervention sets patients up for a high quality of life and a very productive quality of life in their years to come. And then on top of that, there are new therapies that are continually emerging, particularly gene therapy and various biologics, that are going to transform the care we deliver. And these will be concentrated in highly specialized, regionalized areas. And just as an example, if you go to the next slide, please. In the United States, if you're looking at pediatric services, there's been quite a shift in the last decade. And this is a paper published by Cushing and authors in Pediatrics, the journal Pediatrics in 2021. The salient points here on the top left graph is that the total number of pediatric beds across the US has decreased from around 31,000 to just under 28,000. That's a 12% decrease in the last 10 years. If you go to the second panel with the yellow line, you can see the number of hospitals with pediatric units, in other words, having a pediatric focused area in their hospital. Well, those units have decreased by 19%. At the same time, the number of pediatric ICU beds, so taking care of the most complex and critically ill, has increased. And this all serves to indicate that this regionalization of care is seeing a reduction in overall pediatric beds across the country as we regionalize. And these centers that are taking on the complex care need to escalate their resources to provide that care, which is reflected in the pediatric ICU beds. In the lower panel there, you can see the other impact, and that is the distance to travel to pediatric inpatient units or intensive care units has increased over the same time frame. The red here, deep red, reflects 100 miles to the nearest inpatient unit or ICU. And you can see that how that in 2018, there are large areas of the country that simply don't have the same access to care. And therefore, they are dependent and need to have access to providers for their complex problems in other states. Next slide, please. Boston Children's experiences in 2019, so the year prior to COVID, we saw patients from across the 49 states and Washington, DC. And yes, there's a concentration of patients in our New England area, the New York region, and on the Eastern Seaboard. But patients come to us in varying numbers from across the United States because of the care we provide. And our challenge, next slide, please, is that each state has their own requirements for approval to send care out of state. It's around authorization, and in particular around the screening and the enrollment of providers. And we're often in the circumstance where our providers are not enrolled within the particular state Medicaid plan. And we need to strike single case agreements time and time and time again to allow for that patient and their family to receive the care they need. And this is very cumbersome. It's too much red tape, and it threatens the access to care, particularly, as I've said, for those with complex care. And just to remind you that the complex care is a multi-system set of problems. Other systems, other organs involved, comorbidities, and often the care can be unexpected as the disease process evolves. They need innovative treatment and longitudinal care, and very importantly, multidisciplinary coordinated expertise. And we have a number of examples. More recently, a patient with esophageal atresia here, a newborn who had a gap between their esophagus and the stomach. And the patient was born with that gap. It's a recognized problem, often associated with a number of other system problems, particularly a floppy airway, sometimes heart problems, sometimes kidney problems. They need early care. This particular patient was referred to us, no problems with authorization, no issues around payment or anything like that. But it took 7 months for this patient and 3 canceled surgeries before we could finally provide the care that this little one needed. And that was because we needed to enroll 8 separate providers. As I've said, these are multidisciplinary coordinated teams that take care of these patients. We just need a simpler system that facilitates the care. And then finally, congenital heart disease, an area that myself and our next speaker, Howard Jeffries, are very familiar with. And these are patients as well that need expertise in major centers like Boston Children's, like Seattle Children's, and other similar peer organizations across the country. Getting access to care in a timely fashion is critical. And yet, time and again, we run into these barriers because we just are unable to develop or have the appropriate screening and enrollment of the providers who need to provide that care. So thank you for listening. I look forward to any questions that you may have. And with that, I'll pass across to Amy and then on to Howard. Thank you.
Thank you so much, Dr. Lawson. We appreciate your perspective on this. A reminder to folks watching that we will take questions after all the speakers. So if you have questions before Dr. Lawson or in regards to what he just said, please put them in the Q&A and we'll get to them. Our next speaker is Dr. Howard Jeffries of Seattle Children's. Dr. Jeffries is a physician at Seattle Children's, which has been an important partner the hospital has, Seattle Children's, in our work on the Accelerating Kids Access to Care Act. Dr. Jeffries is the medical director for clinical effectiveness at Seattle Children's Hospital and an expert in the areas of cardiac intensive care, informatics, outcomes assessment, and quality improvement, all very relevant components to this conversation. And I will turn it over to him now.
Hi, thank you very much for the opportunity to speak today. And I think you'll see that many of the things that I'm going to talk about actually are similar to what Dr. Lawson just described, and we have a very similar experience, though we are again on the other side of the country in Seattle. As Amy noted, I'm the senior medical director for the regional network at Seattle Children's, as well as an intensive care physician in the cardiac ICU, just like Dr. Lawson. Those two experiences, being connected to the regional network, as well as in the cardiac ICU, has allowed me to see children, again, from across the western part of the United States, who have significant challenges in getting to us. And again, lots of the patients that we see across those regions have complex disease. What I see are patients with complex heart disease. And with that, a lot of the families have Medicaid as their insurance in order to be able to pay for the complex care that the children need. Next slide, please. So at Seattle Children's, our focus is really managing what we call the WWAMI region. So that's the states of Washington, Alaska, Montana, and Idaho. We consider that really the region of the kids that we serve. It is an area that actually is the largest service delivery area for children for any children's hospital. As you can imagine, there is incredible distances that our families have to travel. We see kids that are in very remote communities, north of the Arctic Circle. And we also see kids from eastern Montana. Many of the families that have to get to us, they can't get to us on one flight. They may take 2 or 3 planes at times to be able to get to us. The travel, the challenges are really difficult for the families. And we want to make sure that we are able to reduce any other challenges that families have in getting to us beyond, again, the travel distance. For the kids that we see outside of the state of Washington, we see over 20,000 kids every year who are making that travel to us. And we see over 4,000 children that are coming to us from outside of the region. Again, we know how challenging it is. We hear from our families about being dislocated from their support network, having to care for a sick child, not being able to work. And we want to do everything we can to reduce the opportunity or to reduce the chance that care may be delayed. Within the WWAMI region at Seattle Children's, we take care of children regardless of their ability to pay. It is our mission, it is what we collect, it is what we do with philanthropy, and we collect philanthropy to support that mission. Accordingly, we make sure all of our providers are credentialed, again, across those 4 states. And we have to do it individually with each state because of the rules, but it is vital to us that we make sure all of our providers are enrolled in Medicaid across that region. Our challenge our challenges happen when we are seeing kids that come from outside of the WWAMI region. Similar to, as Dr. Lawson described with at Boston Children's Hospital, we do see many children from outside of what we consider our core region. And for those children, we have to make sure that we get enrolled in Medicaid for each and every one of those that are coming. And again, anytime that we are spending to organize that is a potential delay in the care for those children. As has been stated earlier, the requirements vary from state to state. Some of the states require that we enroll our medical group. Some require that we have the hospital, the medical group, and then each individual provider. And the requirements can be very long, very detailed. We have had times where we've had to enroll our entire medical group, all of the board members, including social security numbers, driver's license numbers, all of this level of detail in order to be able to see a patient. And then once we see that patient, if by the time we see another patient from that same state, it is typically we have to do the whole thing over, and we have expired in our ability to care for kids from that region. Next slide, please. I'd like to highlight a few patient stories, just to give a face little to the issues that our families face. One of the kids that we are currently taking care of is a young boy from a mountain state, and he was born with a craniofacial anomaly. Similar to how Dr. Lawson was describing esophageal atresia, the management of craniofacial syndromes needs a multidisciplinary team. And at Seattle Children's, we have a multidisciplinary team that manages kids with complex craniofacial issues. And this young boy was born with a syndrome which he had airway obstruction and required a tracheostomy early in his life. He was seen by our team, or was scheduled to be seen by our team earlier this year, last fall. We were able to see him last fall because one of the providers who is on our team was enrolled in the Medicaid program from the state where he came from. He was seen by our team, and the decision as a group was that he actually was eligible for surgery. And the plan was to have surgery done this very summer. We started the process in February to get our surgeons and to get our surgical team enrolled in Medicaid so that they could manage him and actually start his process of surgeries. He will need several surgeries, and we had the expectation, again, that this would begin this summer. After all these surgeries, he would be able to be decannulated from his tracheostomy, clearly something that his family are very much looking forward to. It is vital that he gets it done. It reduces his chance of further medical complications. And unfortunately, to date, we are still awaiting enrollment for our surgeons in order for him to come to Seattle and have his first surgery done. And we remain hopeful that it can be done sometime this summer. But as the days kind of tick by, we are increasingly concerned that we're not going to be able to perform this care when he needs it, and when we've talked to his family that he needs it this summer. Another child highlights a similar issue, and this is a 2-year-old boy from a Southwest state. And this young boy was born with several pelvic anomalies, including bladder exstrophy. He was referred to us in October of 2019. So this was a pre-pandemic for a complex reconstruction of his bladder. Unfortunately, again, there were enrollment delays in getting our, again, a multidisciplinary team, which is what's needed to care for this type of complicated problem, for them to be able to see him. Unfortunately, it took many months and the enrollment did not come. Our organization made the decision that we were not going to wait for the enrollment. And so 6 months after waiting, we brought him over to have his surgery done. Now, we knew that we would not get paid because the way enrollment works is that if we're not pre-enrolled, we don't get paid, but we felt that he needed to have his surgery, and we had a multidisciplinary team that was expert at the care he needed. Unfortunately, because he was older when he had the surgery, instead of having a cast at the end of the case, he needed to have external fixators. It kept him in the hospital longer, leading to more morbidity and a much longer kind of recovery than he would have had if he was able to have had his surgery done sooner. So these are just a few examples. Again, we see this on a very frequent basis, and wanted to share these with you just to show, understand how important it is for us to reduce these barriers to care, to reduce delays in care, and anything that we can do to improve our family's ability to get care sooner is really vital for these kids. So thank you very much for allowing me to talk, and thank you, Amy.
Thank you, Dr. Jeffries, for sharing those stories. Our next speaker is a patient parent, a mom who has been on the family side of these challenges as she traveled from another state to Boston Children's this past spring in order for her daughter to have a much needed surgery. And I think that her story really exemplifies what these added burdens can do to a family who's already going through a lot. And I'm so grateful for her willingness to join us and share from her perspective as a mom what this can be like. So I will turn it over now to Jeanette Aviles. Thank you, Jeanette.
Good afternoon. Good afternoon. My name is Jeanette Aviles, and I am the mother of 4 children. The youngest is my 3-year-old daughter named Kylie. Our family lives in Miami, Florida, which is where I am joining you from now. Kylie was born with a heart condition called double outlet right ventricle, or DORV. It is a complicated condition. For most of her life, she has seen a cardiologist and many doctors right here in Florida. Because of this condition, as a young toddler, she wasn't able to play the way other children play. Her oxygen levels were typically low, around the 70s, and she would often get winded even just talking to me. Late last summer, early this year, it became clear that Kylie would need open heart surgery. It was a complicated surgery where they went in to do some repairs, patch up some holes in her heart, and to remove a shunt that she had. The cardiologist that she sees in our home state referred us to Boston Children's Hospital. He said that they are one of the best and one of the only hospitals in the country that could do the type of work on a child's heart. I thought because the cardiologist referred us that it would be simple as 1, 2, 3, but that was not the case. The doctor in Florida said that it needed to happen within 6 months' time. So we scheduled the surgery to happen in Boston in February. But then we hit many obstacles with our Medicaid managed care plan. To tell you the truth, I don't remember all the details, but it was denial after denial and many obstacles and many roadblocks. We even had to reschedule the surgery once because everything wasn't approved in time. So her surgery happened at the end of March instead of February. The whole time we were working to figure out the insurance obstacles, I had many other issues to deal with related to this trip. I had never traveled out of the state for healthcare for Kylie before. I didn't realize that we would have to cover the costs of flights and lodging, which we did manage to do. But trust me when I say this became a full-time job to plan. Boston Children's Hospital worked with us to figure out the Medicaid issues and push back on the managed care plan. Vanessa, who works at the hospital, has seen this happen to other families before, and she encouraged me not to give up. She stayed on top of everything, and I am so grateful to her. I know this took a lot of her time too. I am here today because I want to support this bill and help make it easier for other families who may have an experience like ours. When I learned Boston Children's was working on these issues through a bill in Congress, I was really glad. Our visit involved multiple roadblocks and took a lot of time and resources. If even one of these roadblocks can be removed for families in the future, I think that would be a very positive step, and it could make the difference between whether a child gets the health care that they need or not. Kylie's surgery was a life-saving. I appreciate all the people involved at the hospital and in the Congress who have recognized how hard this can be for families who are already under a lot of stress financially and emotionally. Anything that can be done to ease these burdens should be done. I also want to tell you that Kylie is doing great. The surgery was a success and she is able to live a much normal life as a 3-year-old. Now, after the surgery and when I was able to see her, I noticed her oxygen levels were at the 90s. I started to scream for joy because that was the first time that her oxygen level was that high. Thank you for listening to our story, and thanks to everyone who works on these issues for children. Thank you.
Thank you so much, Jeanette, for sharing Kylie's story with us. And we're so happy to hear that she's doing well today. Our final in-person speaker is going to be Josh Greenberg, who oversees government relations at Boston Children's. And he was one of the earliest to recognize this problem as a policy problem and raise the point that it's not a problem limited to Boston Children's. It impacts hospitals and families across the country. And we need a unified solution, which was the catalyst for us to get together with our peer institutions across the country and develop the bill. So I will turn it over now to Josh. Thanks.
Thanks, Amy. So I wanted to just briefly say to folks here, we've been throwing around the term screening and enrollment, but maybe we haven't completely explained that term. So as an out-of-state provider or an in-state provider, the Medicaid program and rules require you to be screened and enrolled in the Medicaid program before you can provide care. And there are some limited exceptions for, emergencies, et cetera, but that's the general rule. Screening means that the Medicaid program has the opportunity to look at you, either a hospital or a physician or some other kind of provider, and make sure that you're not a bad actor, that you haven't committed fraud in the past or had other criminal behavior, that you're a good clinician, a good hospital in the Medicaid program. And I think we can all agree that making sure that it's only good actors providing care to kids is a worthwhile thing. Enrollment means that you've agreed to participate in the Medicaid program, which has various rules and regulations consistent with those rules and regulations. And so, again, I think a worthwhile endeavor. The challenge in all of this, which I'll try to walk through a little bit, is that those are great rules, but I think they really were set up when thinking about a hospital that's in a specific state. Of course, you would want to assure good actors. You would want to assure that that hospital is enrolled in that state's Medicaid program. But when providing care to 2 or 3 or 5 children from a faraway state, maybe there are other ways to accomplish the same goals without the kind of red tape that I think we've created in the Medicaid program. So my background is as a lawyer and a consumer advocate, and I learned early on that the best policy is made from individual situations. And I think you've heard between our patient family, Jeanette, and our two physician leaders, that there are some pretty compelling patient cases here. And I started to hear from all over our hospital just a lot of frustration about the kinds of things that arose. The timelines for processing screening and enrollment forms from various states could be really extended. Some states only had open windows for enrolling, once a year for a brief period. As I think Dr. Jeffries mentioned, there's churning, so you can enroll and 6 months later you're kicked off because you haven't seen a patient in that 6-month period. You enrolled for one specific patient, completed care, and that patient was kicked off. Or you were kicked off after serving that patient. There was a lot of unpredictability in enrollment. So you're not always sure which clinicians are going to touch or deliver care to a patient because you're not sure what issues are going to arise. These kids can be very, very complicated. And sometimes states require you to have gone all the way through this process before they will even give you a line of sight as to whether they're going to authorize care. So you're in a terrible situation with a very stressed out family dealing with a lot of challenges, and you're trying to figure out whether the state will even approve the care to come to a Boston or a Seattle or one of our peer organizations. And you can't even get through that until this screening and enrollment process completes. So as we started to think about that, we started to question whether we're really serving the objectives of the program. If part of what you're trying to do is prevent fraud, arguably it would be much better to have one national database with all the providers in it and all the hospitals in it, because that way, South Dakota, I'll pick on the state of South Dakota, sending a patient to Boston would be able to consult that national database and get information rather than having to kind of do all of this screening and enrollment by scratch. And that's exactly how the Medicare program works now for grownups and elderly people. There's one national database system, and all Medicare can consult that one database. Operationally, it's just worth noting that all of our hospitals, all of our physicians are enrolled in our home state's Medicaid program. And as we called around the country to the other children's hospitals, they're all enrolled in the Medicare program too, because we see a very small fraction of Medicare patients. And so we tend to enroll in Medicare as well. So all of those key data elements that you would want to look at fraud, to make sure that folks are good providers and are playing by the rules in Medicaid are already available from enrollments that have already occurred. So we went to the other children's hospitals and we quickly found that everybody was having this problem. And we quickly found that it wasn't just the folks who were trying to receive patients. So, Boston, I would say, is more on the receiving end. Folks who were trying to send patients were also running into the same challenges because, it may be that a children's hospital in a smaller state can do certain things and not other things. And so they've tended to develop clinical relationships in order to send patients to bigger centers when they need to. And so they were equally frustrated, I would say, with this process. So we went to the Congress and we worked with several legislative offices to craft this bill, which essentially says if you're enrolled in your own state's Medicaid program and Medicare, that's sufficient. That will build the database we need to build to enable folks to assure that there are good actors providing care and that all the information about them is available to out-of-state Medicaid programs. I want to thank Senator Grassley from Iowa and Senator Bennett from Colorado, who have looked out for kids with medical complexity for many years now. They've sponsored other legislation. They immediately jumped on this. And again, that's a bipartisan duo, Republican and Democrat. And I want to thank Representative Clark and Representative Herrera Butler and on the House side, who did the same. And again, a bipartisan duo who are looking at this issue. They've taken the time to get the language right and to do a lot of pre-vetting with their committees. And we're optimistic that this legislation has real potential to pass the Congress this year. So I would ask, in concluding, all of you to consider reaching out to your own legislators. We have a lot of momentum, I think, around this legislation. There will be opportunities to pass this, I think, in the fall. Here's our opportunity to improve access quite dramatically for these very complicated children, to eliminate red tape that gets in the way of providing care on a timely basis, and to make the Medicaid program more responsive to the needs of children across the country. I will leave it there, Amy, because I know we have some videos from our sponsors.
Yes, thank you, Josh. We are going to hear some brief remarks from the legislators who have championed this bill, of the sort of set of four legislators, the two Democrats and the two Republicans that Josh was talking about. Three of them were able to get us some remarks. I think the other one was traveling out of the country. So we are going to hear from them, some videotaped remarks, and I'll turn it to Alexia now to bring those videos up. Thank you.
Good afternoon, and thank you all for being here today. I'm thrilled to be joining you to talk about the Accelerating Kids Access to Care Act and the ways all of you can help families access life-saving care. I'd also like to thank Boston Children's Hospital for inviting me to speak here today and for all their work advocating on behalf of children who find themselves needing your excellent care. As staff members at children's hospitals, you all know better than anyone that kids with serious health conditions can't wait for life-saving care. Unfortunately, many parents face red tape, legal hurdles, or geographic challenges when it comes to getting their children care, and they shouldn't have to. Too often, children with complex medical needs can't always find the highly specialized care they need in their home states. When that happens, parents are forced into the difficult process of working with healthcare providers and state Medicaid officials to find out-of-state providers who can care for their child's needs. That process can be challenging, stressful, and time-consuming, delaying children and their families from receiving treatment. In some cases, these sick kids don't receive access to care at all. Knowing that a cure could be out there, that life-saving treatment is just a car ride away, but red tape and state lines stand in their way is cruel and heartbreaking. But it doesn't have to be like this. The Accelerating Kids Access to Care Act would provide states with the ability to use a streamlined screening and enrollment process for out-of-state pediatric care providers that need to enroll in another state's Medicaid program, while still safeguarding the program's integrity. These changes would help reduce the regulatory burdens that slow down or prohibit children from receiving the care they need without impacting anyone's safety or the quality of that care. This isn't political and it isn't complicated. That's why my colleagues from both sides of the aisle came together to introduce the bipartisan, bicameral Accelerating Kids Access to Care Act. In the House, Representative Jamie Herrera Butler of Washington and I introduced this bill with the simple goal of helping sick children get better. But we didn't do it alone. Former Representative Joe Kennedy was a key partner in the creation of this legislation, as were all of you. The unique collaborations between children's hospitals, all working towards the same objective, is what led to the shared effort to develop this legislation. And now we're calling on you once again to reach out to your own members of Congress to ask them to co-sponsor the Accelerating Kids Access to Care Act. With enough support, we can get this passed in the House and the Senate and signed into law by President Biden. Children with life-threatening illnesses can't wait, and neither can we. Thank you all for your work and your support of this bill, and I look forward to working with you all to help every Massachusetts kid live a healthy, happy life.
Senator Bennett of Colorado and I, Senator Chuck Grassley of Iowa, have been working very closely to help the special medical needs of kids. We passed the ACE Kids Act a couple years ago. Now we have to follow on with adjustments to that act so that it will cut the red tape so that these kids that have to go through several different avenues to get the full complement of health care that they need will be able to access all these systems with that less red tape and to get them the help they need. There's no reason that these families should have to struggle to understand 5 to 10 different health care programs, a lot of them government programs that can help them get the help that their kids need. These ACE kids need this help, and this follow-on legislation that Senator Bennett and I are introducing and hope to get passed will speed up this process.
Hi there, this is Congresswoman Jamie Herrera Butler. Thank you so much for joining this briefing today with Boston Children's Hospital as we discuss legislation I've introduced into Congress, the Accelerating Kids Access to Care Act. Ensuring access to high-quality, affordable health care has always been a top priority of mine. We need to make sure it always remains a top priority here in Congress. Part of that includes making sure that kids have access to the health care that they need when they need it. And that's where the Accelerating Kids Access to Care Act comes into play. If a child needs access to specialized medical care, they shouldn't be hindered by their zip code or their income level. And Congress can help remove barriers that keep kids from obtaining the treatment that they need. And that's why this bill is so important. Children with complex medical needs cannot always receive highly specialized care that they need within their home state. And when that happens, parents must work with healthcare providers and state Medicaid officials to find out-of-state providers to be able to provide the necessary medical care. The process is difficult and full of red tape. I'm sure many of you know this. I've experienced it. And delaying children and their families from receiving the care that they desperately need. So in some cases, they don't ever receive the care at all. This legislation would provide states with the ability to use a streamlined screening and enrollment process for out-of-state pediatric care providers. I know you guys are all thinking this should have been done a while ago, but with that reform, we'll make it much simpler for providers to enroll in another state's Medicaid program. And in turn, it would help reduce the red tape and the regulatory burdens that slow down or in certain cases prohibit children from receiving the care that they need. I am so pleased to work on this piece of legislation in Congress. I'll continue pushing it until we get it across the finish line so we can help kids and families access healthcare across this country. Again, thank you for taking the time to attend this briefing and wanting to learn more about this legislation. I appreciate it. Thanks for all you do. Take care.
So it's great to hear from them in their words about their support and their commitment to advancing the bill in Congress, hopefully soon. So several of them mentioned, that there are actions that you can take. So we're going to talk a little bit now about one of those actions that I hope people are able to do when this webinar wraps up. As you know, we talked about them. We are fortunate to have this core group of legislators leading the effort in Washington, D.C. on this issue, but they can't do it alone. So the bill was introduced just recently, and it has 30 co-sponsors in the House. 30 members of the House have signed on and basically said, we support this bill. We'll support it if it comes to a vote. 6 co-sponsors in the Senate. So that's 30 out of 435 House members and 6 out of 100 senators. So we think we can get some more, especially with the representation across the country of people who are watching this call and interested in this issue. So if the leadership of the Congress sees that a bill has widespread support that crosses party lines and geographies, it's much more likely to move quickly. So that's what we are aiming for now. I don't think there's a lot of opposition to this concept of this bill in Congress. It's not an expensive bill to implement. Everyone tends to agree that children should have access to the care they need. But it is somewhat of a complicated issue, and it's limited to a small group of people and providers. So we just have to be kind of loud about it. So that's why we're here today, to educate about it and to ask people to take an action. So to that end, we have prepared a way for you watching at home or in your offices to click on a link and send we have a pre-written but customizable letter that I'm going to show you in a minute that you can send by email to your own elected officials, asking them to co-sponsor the Accelerating Kids Access to Care Act. Nick put a link in the chat that you can click on to see if your member of Congress perhaps already is co-sponsoring the bill, which is a good thing to know. And what you will do in order to send the email to your members of Congress, I'm going to share my screen here. So click on the link that Nick will also put into the chat, and it will look like this. They'll come to a screen that looks like this one. And on the left is some information for you to read, sort of refreshing what we've talked about here today, what the bill does, who the sponsors are, and it says your voice is needed now. Then if you look over in the blue box, it asks for just a few pieces of information from you so that the program can connect you with your US representative and your 2 US senators. If you don't know who they are, that's okay. You just put your address in there, your home address and the city you live in, and it will pull that information up for you. When you're sending this email that will go directly to them, it'll go to your representative and your 2 senators. You want to personalize it a little bit just so that they know who you are and why you're writing to them to ask them to do this. I could write to all 100 senators, but I live in Boston, Massachusetts. So the 2 that are going to care most about me and what I have to say would be Elizabeth Warren and Ed Markey. If you live in another state, you have other senators. They want to hear from you, not me. So you want to, in the first line here, just customize it a bit. It says, I am writing to you as and there's a blank line. So you should put in there, if you're a parent of a child with complex medical needs, you should say that. If you work for an organization where you see what families go through, you should talk about that. If you work at a hospital, you should say that. So customize that first sentence to say what your interest is. If you're just a person who cares about kids, you can say that too. The first sentence in the second paragraph is also customizable. And this is where if you have some personal experience with this, and I think a lot of you watching this webinar probably do, you should describe that there, just to personalize it a bit. So the first sentence in the first paragraph, first sentence in the second paragraph. The rest of it is all, look at it, make sure you understand it, but it describes what happens in these situations, how the bill would address it. And at the end, it has an ask for the member of Congress, the senator, to co-sponsor. These are the bill numbers. You can leave them in there. S1544, HR 3089 are the bill numbers in Congress. That'll help them know where to look for it. And you should change where it says name here. You should put your own name. So if it were me doing it, I would just highlight that and put my own name in there. Once you've done that, if you have your address and information there, then when you click take action, it will bring up your own members of Congress. So in my case, it brings up Elizabeth Warren, Ed Markey, and Stephen Lynch. And I've already done this. I've already clicked on take action and sent this letter to them. But I wanted to show you what it will look like. Their pictures will pop up there. You also see their phone numbers will pop up there, their DC offices. If you're more comfortable calling their office instead of sending this email, you can do that too. And the person who answers the phone, I'm sure will be very happy to hear from you and to take that information down, that you're interested in having them co-sponsor the Accelerating Kids Access to Care Act. I used to work in a congressional office a long time ago on Capitol Hill, and was one of the people who answered those phones. And I can tell you, they do want to hear what their constituents have to say. You make it clear that you live in their state, in their district. They should be interested. They're there to represent you. So that's why we've created this, and we're asking you across the country to reach out to your own members of Congress. So please click on that link, which is in the chat, and it will be included in our follow-up materials, and send that email. So we are now going to transition to a question and answer portion of the event. So if folks have questions for any of the panelists who spoke, for Doctors Lawson, Jeffries, for Josh, or for Jeanette, they can put them in the chat. I have a couple of questions that actually kind of came in while people were speaking or with the registration. So if folks who are on the panel could maybe turn your cameras back on so people see that you're available, I'll direct the questions to the right people. That would be great. Thank you, everyone. This first question here, it's for, and you touched upon it a bit, but for the clinicians, really, is there a set of conditions or condition that you and your colleagues more routinely see with children traveling from out of state, sometimes across the country? Cardiac came up quite a bit, and of course it was Jeanette's example, but maybe you could talk a bit more about what kinds of kids and what kinds of conditions that you tend to see. I don't know who wants to take it first, Dr. Lawson or Dr. Jeffries.
Howard, perhaps I can kick off and then you can join it. I think we touched on a range of conditions, both of us. Certainly children born with heart disease are one group of patients that, particularly very complex malformations of the heart, need complex repairs and often over a longitudinal period of time. And the major centers, like Seattle, like Boston Children's, have created that expertise to manage the very complex conditions. And I'm so pleased, Jeanette, to hear how well your daughter did, but that's a very good example. We also see patients born with malformations in their airway, malformations in their gastrointestinal tract, whether it be from the esophagus all the way through to the lower bowel as well. So they're often very complex and associated with other genetic conditions as well. So they bring other comorbidities. And once again, it's not a simple procedural fix. You know, there's complex planning, complex teams involved to deliver the right care for these patients. And I think what we're seeing more so now is increasingly is that the genetic understanding underpinning many of the diseases that we're now seeing is being well determined. And that means that very rare conditions are coming to centers of excellence. Doesn't mean that we just don't treat rare conditions for patients born in our region or in our area. We have to take these patients who we want to provide the care for these patients coming from multiple areas. And I think we're identifying new therapies as a result of the genetic underpinning of many diseases. And that's very unique to pediatrics. And the earlier intervention with whether it be some sort of gene therapy or new biologics, gene editing, it all will result in some modification to that disease. That's an important area of care that's not able to be performed everywhere. It has to be centralized and regionalized to areas of expertise. We should not have any barriers related to borders and geography to get that care. Howard.
Thanks, Peter. Yeah, I mean, I echo many of the things that Dr. Lawson stated here. I would say, again, as I mentioned earlier, really, in my perspective, it's the the complicated kids that need multidisciplinary care, that are the ones that are requiring transfer or moving to the major centers in the country. And beyond the areas that Dr. Lawson mentioned, I also think of kids that need transplantation, tend to have to travel. And then the other are kids with complicated oncologic, complicated cancers needing bone marrow transplant. Those tend to be the kids that we tend to have coming to us from places, again, outside of our typical region. And I think what you'll find is that various of the children's hospitals have areas where they have expertise. And for those specific areas, they may have national, international experts. And for those complicated diseases, families will find those experts and want to be managed by those individuals and teams.
Thanks both for those answers. This next question just came in the Q&A, and could be for the clinicians, may actually be for Josh. What typically happens if Medicaid doesn't approve a procedure on the clinician's recommended timeline?
Well, that's a great question. So I think that there are a couple of different things that can happen, really. So one is if there is some amount of time to challenge the decision, both patients and sometimes providers have the right to challenge that decision. And I think you heard in Jeanette's case that there was a lot of back and forth between her and the folks here at Boston Children's with the Medicaid plan that she was working with to challenge their decision making around various things. That's one option. Two, sometimes legitimately a Medicaid program or a plan might say, we prefer to send this case to Seattle instead of to Boston. And to a certain extent, it is within the rights, the realm of what the Medicaid program is trying to do, that they can develop their own networks for certain kinds of care. So it may be that they're not approving it at a certain place, but they're approving it at an equally good place elsewhere. And I think we'd say that's a legitimate thing to have happen. And then sometimes, as Peter will tell you, and probably Dr. Jeffries, you just don't get paid. Right? You know that you have to do what you need to do for the child. We have a whole process for our clinicians to look at that, and if we need to do it, we'll do it and argue about money and getting paid after the fact.
This next question is for Jeanette. You have such a compelling story about your care journey. Can you talk a bit more about how your child's care is coordinated by both the team at Boston Children's, but also by your local doctors, for example, who manages your Kylie's care on a day-to-day basis?
She's seen here in Florida by her local cardiologist, Dr. Abdul Aldusani, and he communicates with Dr. Danito and Dr. Powell in Boston Children's Hospital. They communicate.
And her primary care and any other services she need are able to be handled in Florida?
Yes.
Good. That sounds right. Another question. Let's see. This is for the clinicians. How challenging is it to be tasked with providing follow-up care, including prescribing and follow-up visits, only to find out you are no longer enrolled in the child's state Medicaid program? When this happens, what are the ramifications for the child and family, and how do you navigate this situation?
Unfortunately, not uncommon. So when patients come here for their complex care, an important component of the care we provide has to be the longitudinal component to it, and their follow-up back with their partner, just like Jeanette was describing the relationship with their cardiologist, with the team here in Boston. Those relationships are important and have to continue. What gets very frustrating and difficult is that many of the Medicaid plans look at isolated visits as a one-off, and they don't see the longitudinal care. So you might have, after a lot of red tape, get the approval to provide a particular piece of care, but you've got to go back and redo that again. So you have to stay there and keep doing it. It's the nature of it is very cumbersome. It's very frustrating. Lots of phone calls, and I have to say that our teams here in not only government relations but our enrollment teams, our patient financial services teams are just tremendous at their diligence and staying on top of all this. But it's unnecessary. And then in the end, if we are running into ongoing problems and it's just becoming insurmountable, and it's a patient that we have continued and started treatment, that we have the expertise to be able to continue that care, then we just continue to provide the care. Josh mentioned that it may be free care. We have that sense that we're very committed to making sure that we continue the care that we not only started, but make sure that it continues for the duration of the care that that child needs.
Thank you. One more question for Josh, and this brings up the ACE Kids Act, which Senator Grassley mentioned, and I think has come up a little bit in this conversation. How does this tie into the ACE Kids Act, and how to convince states that they should be part of this?
So the ACE Kids Act was Senator Grassley, Senator Bennett got a law passed a few years back that created a structure for medically complex children to receive enhanced care through medical homes, better coordinated care, including behavioral health services, care management services, et cetera. The therapies that Peter briefly touched on earlier, physical, PT, OT, et cetera. And there was a view that they might have to receive that care across state lines. So the legislation actually creates incentives for states to opt into the ACE Kids program, to develop these medical homes and participate. And there's some, I'll call it back of the office things that are pretty cool in terms of improving quality and collecting data so that you can start to see what works and what doesn't work around the care delivery to these kids. But the challenge, I think Senator Grassley kind of alluded to it in his remarks, that's all well and good, but if you can't easily get across the state line because the provider is not screened and enrolled in the Medicaid program, it sort of all falls apart, right? So that's why I think he, as a longtime advocate for kids with special health needs, views this as an add-on to a piece of legislation that he's already done, that now he's tackling some of these red tape issues that are getting in the way of effective implementation of that law.
One more question that's come in that I think goes to Josh, or really anyone, but what arguments could the bill's opponents possibly make against this bill? I'll start by saying I don't see it as particularly controversial. Most people we've talked to have understood it. I think a lot of it is education. We need to talk about it and for them to know that it's happening more. I think a lot of people don't realize this goes on.
I'm going to assert one thing, and our physicians may have views on this too, just from their own vantage points. But I think that many state Medicaid programs, and I'm saying this with all sincerity, have very old computer systems, or in the alternative, because their computer systems are so old, they contract with vendors to use their computer systems. And so all of these places, in order to make this bill work, would have to tinker with their computer systems, I think, to get the right information. And that's why I think having a national standard around all of this facilitates it, because it doesn't become a one-off conversation. I think if CMS were in the position to say, here are the common data elements that you should all be collecting, then all the vendors are going to come forward like they have in the EMR world and start to structure their systems to be able to import this information. So I know that sounds like a little cynical, but it actually isn't. I think that probably it's that operational challenge that may be the biggest challenge.
I would add one more thing, Josh, if I can. I think that we're asking people in other states Medicaid plans to understand what is trying to be delivered out of state and the care that will be delivered. And it's complex, it's new, it's evolving all the time as new research comes through, as experience increases. And I think it must be hard for some of the plans to really understand and grapple with that as to what's the standard of care versus what's the right care. And so I think part of our job is to make sure that we can provide the most compelling reasons and evidence for why the provision of care is necessary out of state.
Makes sense. I think we have time for one more question, and this one that's come in is a bit related to what we just discussed, and it's for Jeanette. If anyone doubted the need for a change in the law to facilitate provider screening and enrollment to enable more timely delivery of care to children like yours, what would you say to them?
We need it. We need this bill because it was a lot to deal with, and financially, we need the bill to pass so like that other families don't have to go through what I went through, and then make it a lot easier for the kids to get the care that they need, like mine did.
Yes, we're so glad she did. We agree, and thank you for sharing your story. I think that
Thank you.
that sums it up. I think we can wrap this event here. If folks have questions after they log off or want to send questions to me directly, feel free. My email was put in the chat. We can even put it back there. Happy to facilitate connections with folks if there are specific cases to follow up on or just more detailed questions. But thank you everyone for joining. Please click on the link, send that email to your legislators, let them know about this bill. They might just not know about it and be perfectly happy to sign on. So we'd ask you to do that. And thank you for joining, and have a good rest of your day. Thank you again to all the panelists for taking the time to share with us today. Really appreciate it. Thanks. And I think that's a wrap. Thanks, everyone.
Bye-bye.
Bye.